Welcome back, everybody. I hope you enjoyed your lunch and you're not feeling too postprandial. Bearing in mind the topic of the next talk, I was wondering if we should put 10 milligrams of dexamethasone on everybody's seat to make sure you stay awake, but that would be wrong. We're not going to do that. And in fact, you won't need it because we've got a really excellent speaker. We've got Angelica Edge, who's a clinical nurse specialist in myeloma from my part of South London. It's from St George's Hospital, and she's going to talk about steroids in myeloma.
Hello, hi. Hope you are full and from lunch. So we're going to talk about steroids. I think a lot of people have said that steroids are either their favourite thing or their worst thing about the treatment. Okay, so what this talk will cover today is what steroids are and why we actually use them in myeloma treatment, what the physical and psychological side effects are of steroids, and hopefully how to manage some of these side effects. So the take-home message that we want to kind of say today is that steroids are a really important part of myeloma treatment. Most of the regimes, actually all of the regimes, do include a steroid element. So unfortunately, we can't really get away from that. And then that the side effects are manageable. I think in a lot of the conversation I've had today, it is trying to find out what is manageable and what isn't. And then we're trying to support patients through treatment, through different lifestyle measures, and then also planning ahead when you are getting the steroids. Another take-home message is don't be afraid to ask your health care team questions, and also to ask whether steroids are still needed or in this part of treatment. So what are steroids? So steroids are naturally produced in the body. There's a type of steroid called corticosteroids, which are made in the adrenal glands by the kidneys. So there's a type that is released in response to stress and inflammation, and the mineral corticosteroids control salts and electrolytes. So they are naturally found within our bodies, but it's not the same as anabolic steroids like testosterone, but obviously we're giving them at higher doses. So like you probably all know, the main one that we do use a lot is dexamethasone. Sometimes we use prednisolone, methylprednisolone, and hydrocortisone. So those are the types that we do use. So they can come in oral tablets, the tiny little tablets that you have, sometimes intravenous, especially on the days that you have maybe an isatuximab or a daratumumab pre-meds. They're normally given every week, or sometimes we can split the dose to twice a week as well. So why do we use steroids in myeloma? So the uses for steroids is as a chemotherapy, to reduce inflammation, prevent or treat infusion-related reactions, like the daratumumabs and the isatuximabs, and as an anti-sickness. So I think we use it most commonly for, melphalan. So using the steroids as a chemotherapy, they work well within the treatment regime because they are also helping with cause cell death of the plasma cells, which is obviously what we want. So they are they cause cell death to both normal and abnormal cells and the other immune system cells. It leads to other side effects like increased infection risk, and then obviously, as you all know, higher doses do come with larger side effects as well. So it works alongside other chemotherapy treatments to boost effectiveness, and I think patients have told me that actually steroids do act quite quickly, especially for things like pain. So other uses of the steroids, not only to help with the actual chemo-killing, cell-killing with the chemo, is reduce inflammation. So many patients start off their treatment, with quite a lot of bone pain. So that can help with reducing the inflammation. So actually patients do feel quite a lot of pain relief quite quickly. After radiotherapy as well, sometimes they're given doses of steroids to reduce the inflammation at that site where they've had radiotherapy. And other things like in other inflammatory conditions. So sometimes patients do also have drug rashes and things like that come from the treatment, such as lenalidomide and things. Infusion-related reactions, so we've got the daratumumabs and the isatuximabs that come with the pre-med steroids before they actually have the actual dose. And then if you've had a little bit of a reaction to the daratumumab and the isatuximab, we give you a smaller dose 2 or 3 days after to have at home if needed. But again, that's not always needed. We do give it to you, and it is not always recommended to take it if you find it really difficult. And then anti-sickness. So the anti-sickness is generally used if it's like high-dose melphalan before you have your autologous stem cell transplant. So, the side effects of steroids. I think everyone knows that they have side effects. And I think we do go into detail when we're consenting for the treatment, but a lot of the time I think we're talking about the side effects of the actual sort of cytotoxic drugs. So the drugs with long names, complicated names that no one can really say. But these steroids we do give them in high doses, and they do have quite a few side effects. So these are some side effects. So we've got gut problems, increased risk of infection, increased blood sugars, increased appetite, difficulty sleeping, fluid retention, weight gain, and psychological effects. So it's not a small side effect profile that they have. So let's go into some of the physical side effects. So we've got gut problems. So we've got indigestion, heartburn, and upset tummy, and that's obviously one of the things that patients do come up to me a lot and say this has really caused me a lot of distress with gut problems. Stomach ulceration, it can lead to, but hopefully we would be putting you on a sort of a PPI, so like an omeprazole, lansoprazole, to help with that. So it doesn't often lead to that too often. Antacids do reduce the side effects, like omeprazole. Increase appetite and weight gain. So patients do tell me that they do reach for the donuts on those steroid days, and actually they bring in some Krispy Kremes as well to the day unit to try and even out their calorie intake. They also, it does make you, it can make you put on weight if you're not keeping an eye on what you're actually eating and what you're eating on those steroid days. But some patients actually do think that it's a positive thing in a way, because if you have lost quite a lot of weight before your diagnosis or whilst your myeloma has been quite active, this might be something, if you've lost your appetite, this might actually be something to help gain, a few pounds, not excessive, but something to help, get you through the rest of the treatment. So blood sugars, so if you have diabetes or sort of on the borderline of having diabetes, the steroids are likely to disrupt your blood sugar control. And if you're kind of on the cusp, or if you have diabetes already, it can induce diabetes. So if you have pre-diabetes, it can kind of push you over into having diabetes. So what we say, if we take a past medical history of the patient, if you have diabetes already, normally the team will get your local diabetes team to understand that you're going to be on high-dose steroids for a while, and so they often would book an appointment around your GP to manage this, and then focus carefully on diet. It's easily said than done, because sometimes you have good days where you really do want to not eat too much, and some days you just need a duvet day with some donuts. If you don't have diabetes, you still need regular blood sugar monitoring, and then would just focus on diet, and if the blood sugar goes too high, we will do a referral to the diabetes team. But likely the blood glucose changes will be when you're on steroids. So when you're off steroids eventually, hopefully the risk of diabetes will go and your blood sugar should normalize. Another physical side effect is fluid retention. So this doesn't tend to happen instantly, but patients do say that towards probably the first or second month that they're on treatment, the fluid does accumulate into their ankles. They get swollen ankles, sometimes abdomen, and then sometimes they do feel breathless as well. Hopefully, on visits to the hospital, you'll be able to tell the nurse that's looking after you, my ankles are puffy, and they'll be able to weigh you as well to see how much weight you might have accumulated. So things that we can help with is elevating feet and legs. So if you're sat down for long periods of time, just try and elevate them. Easier said than done when you have a brace sometimes on and they're already uncomfortable, so you can't really get that sort of shape where you have your legs up if you have a restrictive brace on. And then water tablets. So sometimes we give you diuretics to try and get some of that fluid off. But we use it quite cautiously as well. There's a lot of other things going on as well. And then, we can talk about steroid reduction as well to help with the fluid retention. So this is one that isn't talked about as much sometimes, is the increased risk of infection. So steroids affect both normal and abnormal myeloma plasma cells. So with long-term use, you can have increased bacterial and viral and fungal infections. So that's why we give you the supportive medication, the preventative antibiotics, antivirals and antifungals to try and help prevent the common types. Obviously, they don't prevent all infections, and now the GPs are offering vaccinations for things like flu, COVID. There's a new RSV vaccine that I think they're rolling out for a certain number of patients. So we'd always try to suggest that you get those as well, alongside some of your preventative tablets. So we've also got muscle weakness for the physical side effects. With increased long steroid use, sometimes patients do feel that they feel muscle weakness, or they feel things are, movement is a little bit more difficult. So I think trying to maintain physical activity and exercise is a good way to try and keep those strengths, those muscle strengths up. So I know there's, I think Myeloma UK do a little exercise program, from an armchair bit to a bit more exercise as well. We can, your team, if the muscle weakness is severe, your team may consider reducing or stopping the steroids too. Muscle cramps. So this is another side effect. It can be due to changes in your blood electrolytes. So that's why the team will check salts in your blood regularly when you come up to the hospital, just to see if there's anything that they could add. I know patients don't really enjoy having the magnesium, the potassium supplements orally because they do taste awful, but sometimes they can contribute to muscle cramps. It can be due to lenalidomide as well, and sometimes we say to patients to have tonic water. And then occasionally it's due to steroid withdrawal. So bone weakening and the risk of osteoporosis is a risk with long-term use of steroids. So to reduce this, we do offer bisphosphonates. So alongside the treatment, we have Zamita, the calcium and the vitamin D. We do say, obviously, to help with this, sunlight and exercise. Exercise is great. Sunlight, obviously, to be careful and always use a good factor when you are. And also in England, there's not that much sunlight, so that's not the best. But yeah, so that's what we're trying to do to counteract the bone weakening due to the steroids. Changes to the skin, nails, and eyes. This can cause thinning skin, as well as easy bruising. Brittle nails, one of the side effects which patients have noticed actually is premature cataracts. So their vision sometimes does deteriorate, and the formation of cataracts can occur a little bit faster than they would naturally if they were to get cataracts. And just to say, most of these side effects are likely to develop with long-term steroid use rather than it being, within a couple of months. So the psychological side effects is something that we don't really talk about or very much because, well, I guess people just, don't really think that there's anything that we can really do to help with some of these side effects. So difficulty sleeping is one of the most common side effects. So patients are advised to take them early in the morning as soon as they get up, so that hopefully by the time they go to sleep, they would have worn off a little bit. But some people, they haven't worn off at all, so they're absolutely wide awake at night. So then we try and say, well, why don't we take them at night and see, which sounds a bit odd, but why don't we take them at night and see if they have worn off by the time, they haven't taken effect in the night time, and then you'll have a better sleep pattern. It's a bit of trial and error, really, as to what you prefer. Increased energy, I think many people find this. I think a lot of people find it a positive to the steroid side effects. Increased motivation, increased positivity. Many patients say that they get the hoovering done on good days of steroids. But it also does wear off at the end of the week or whenever you finish taking the steroids. So by the time it's due for another dose of steroids, you're sort of in the low point of it. So you've got a slump or fatigue day or two. It could last longer. And then obviously with that, sometimes it comes with like low mood or depression as well. So you've got a bit of ups and downs there with the energy. And irritability. So I think it says here, family and friends know best. I think carers do say that their relatives do become a lot shorter with them. Maybe their patience is not as good on steroid days. And I think that can sometimes cause disruption in relationships. So that's not always noted to us in the medical team, but I think it is an important one to note when you do see your team. So how to manage these side effects? So I think, like I said, one of the best things to do is to discuss possible changes to steroid treatment with your healthcare team. So I think that's what's really important about clinic visits. When you have the opportunity to discuss change in treatments or how it's affecting you, I think this is a good place to do it is your clinic appointments. And then also maybe having a diary for when you do have those good peaks and the bad peaks, and see how long it might, you know, the ups and downs of your week. Maybe there might be, maybe you find it easier on some days to cope with it because you're familiar with what the side effects profile is going to be at that point in the week. So you can plan around, I don't know, doing the hoovering on the steroid day and then having a duvet day on the day that you're not. Supportive treatment, so obviously we have the antacids, the bone protection, the antibiotics that are supportive treatments to help counteract some of the steroid side effects. And then lifestyle measures, so diet and exercise, I think is, I know it's said a lot to try and help with things, but I do think diet and exercise do support managing these side effects as well. So if you're finding it difficult to do it by yourself, then obviously there's formal support like dietitians and physios and things that you can also touch base with in the hospital environment. So impact on family and friends. I think speaking to carers and families out there, I've noticed that the mood is quite a topic that people like to talk to me about in relation to their relationship with their loved ones. So their mood is something that is quite difficult to control with the steroids. The energy levels as well, physical activity, and letting people know how you feel. So family will often notice before you do that there's a big impact with the steroids. And so, again, it's good to relay this to your healthcare team. This is the next slide. Communication with your healthcare team. So, again, I'm going to stress the importance of telling your healthcare team about the side effects. Make sure that you don't have to wait until the end of the month to have that conversation. You can tell your clinical nurse specialist, if you're really struggling, and then at the end of the month, we can with your healthcare team, they can decide on the best way forward for how we deal with some of the side effects. So you can ask whether steroids are still needed. So if you're on the maintenance side, is there a chance that the steroids can be reduced a little bit if your myeloma is under control and it's behaving the way it should do? Could you reduce these steroids if it's really affecting you? Write down the questions for the next appointment as well. Yes. So this talk has covered what steroids are, how they work and when they are used, the physical and psychological side effects of the steroids, and how to manage these side effects. Again, the three take-home messages are, unfortunately, steroids are an important part of myeloma treatment, and they work really well with the other myeloma treatment, otherwise we wouldn't use them, but they do have side effects. Most of these side effects can be manageable. We can work through some of the supportive treatments, the lifestyle measures, and planning ahead on how we best cope with times of highs and lows within the week or within the month. But also, don't be afraid to ask your healthcare team questions, including whether steroids are still needed. You can find some more information on the side effects of the common ones that we use, dexamethasone and prednisolone, and also the book, The Small Things That Make a Difference, does have little hints and tips for patients, because this is a very widely talked about issue with steroids in the book, and there might be some hints and tips to help families and carers about how to anticipate the aspects of steroid side effects. And then there's information from Myeloma UK, support groups, booklets, the peer body service, which some people have said is really good. So they match you up with someone that's going through a similar experience to you, so you can talk about coping strategies and things like that. And there's online discussion forums for patients and also families as well, carers. Thank you. Any questions?
Hi, I didn't quite catch what you said about the long-term effects of steroids. I've been off them for a while now, although I took them for a while too, and I still find I've got bruising and brittle nails and that sort of thing. Is that likely to be due to the steroids?
I think it can be a side effect, yes, but it could also be side effects of some of the other treatment as well. I know sometimes like lenalidomide and some of the other treatments do cause skin changes, nail changes and things like that. It's quite hard to differentiate sometimes without taking everything off to see what's actually causing it.
It's just there are two practical tips that I picked up over the years. One of them is that some of the American sites are splitting the dose for 2 consecutive days. Sorry, you may have said that and I may have missed it. But if you're prescribed 40 milligrams on day 1 every week, and that's horrible for you, it's sometimes much more tolerable to take 20 on day 1 and 2, and then day 8 and 9, for example. And there doesn't seem to be any difference in efficacy. So that's one thing that works for some people. The second thing is there was a study, I think last year, that showed that with daratumumab, you can drop the steroids by about cycle 3, because they're given preventively, often to prevent people getting a reaction. But actually, you don't need any steroids with your regime from about cycle 3 onwards. And yet, with the computers, it's going it's prescribed automatically. So you might have to ask for them to take it out.
Yeah.
I'm losing my voice. I just wanted to ask, so when steroids are used with DARA as an immunotherapy treatment, is it necessary to keep the steroids going for the duration of that?
So I didn't catch the beginning of that.
If steroids are used, if dexamethasone and daratumumab are used together as an immunotherapy regime, is it necessary to keep the steroids going?
So like...
Yes, well, when it's part of the treatment, you need it. But if it's been given preventively with the DARA, which often continues much later,
Yeah.
It's important to differentiate the use of dexamethasone for treatment, in which it's needed, and it's important, if you're really having difficulties, discuss it with the doctor about dose reducing or changing the way in which is given. But with the DARA, when it's been given as maintenance, it is not necessary to have dexamethasone with it to prevent a reaction. And so that's later on, often when the dexamethasone is no longer part of the treatment.
Yeah, so that's why I've said, ask your healthcare team if it's actually still necessary to have the dexamethasone, so then they could explain to you where you are in your treatment so that you can understand if it's being used with the treatment or just for to prevent a reaction from the daratumumab. Anyone else? That's it?
Right.
Great.
Very good.
Oh, you've got one. just one there.
Oh, we have got one.
Sorry.
Yes, sorry.
Put my hand up right at the last minute.
Have a microphone? Just hang on a sec. We'll...
Just down here. Sorry. I want to point at you.
Thank you. It was just a quick question about the risk of, you mentioned about the risk of diabetes. Is there a proportion of how many patients on dexamethasone with myeloma develop diabetes? How big a risk is that?
I'm not sure what the exact proportion of patients do get diabetes, but what the main thing is that we would check blood sugar levels routinely within the cycles and beginning with the high doses of steroids as well, and see how that is. And obviously if you're pre-diabetic or anything like that, we'd probably keep a closer eye on blood sugar levels just to make sure. Okay.
Thanks. As a clinical nurse specialist, do you give that amount of information to your patients when they're first put on something like dexamethasone? And I appreciate everybody reacts differently, or do you wait until they come to you? Just from personal experience, when I was on Dex, I didn't really appreciate the side effects until I was off it, and then realised quite how horrible I'd been.
Yeah. No, I think that is a good message, really, because no, I probably don't go into as much detail as a clinical nurse specialist at the beginning of when they start the treatment, because I think already there's so much information being given to you, either at diagnosis or even a switch of treatment. You still have to get your head around how it's given, how many times you have to come into hospital, what the cycle looks like in a month, and all those sorts of different things. So I give the booklet, which is actually really good, about dexamethasone. I don't know how many people actually read it or not, because it's, but they do make it manageable with their little booklets. I think if someone has had a history of not tolerating steroids very well before, sometimes I'll go into detail about what it is that they've struggled with last time they were on treatment or last time they were on a high dose, and see if there's anything like, with our healthcare team that we could help with, like splitting the doses or, those sorts of things. But yes, I think sometimes, like you say, good feedback would be maybe to go into a little bit more detail about the fact that steroids do cause a lot of side effects, or can do. Sometimes patients don't even feel it, or they don't admit that they have any other issues with steroids.
You've mentioned several times high doses of dexamethasone. It would be helpful to know what you mean by that. And also, I've seen in the hospital pharmacy something you can get a card if you have dexamethasone, and I wondered in what circumstances you'd need to carry a card. Thank you.
So I think we're talking about 20 or 40 milligrams as like high doses of steroids. I mean, obviously, I think any steroid doses, even though they're tiny tablets, I think they're quite potent. I have seen the dexamethasone, or the steroid cards. They normally get put in with your. Are you talking about the sort of weaning dose of steroid cards and the alert cards, or I have seen them. I just don't know. I know that we give them to patients when they get given a new box of steroids, so they should, like pharmacy, put them in every dose, really. There's a little blue card supposed to be in there to tell you like the side effects of steroids, I think. Yeah. I think that's what you mean. I'm not sure.
I think from having seen the poster, it's more like so other people know you're on them. So
Okay.
like the daratumumab, you have a card, don't you?
Oh, I'm not sure that I've seen like alert cards for steroids, but maybe in certain hospitals they might have steroids indication cards. I've not seen them myself, but it would be useful. But then you have a whole wallet of cards, alert cards.
It's worth mentioning, I was talking earlier how treatments develop. It's not that long ago that treatment regimes, I'm looking at Stella here, she'll remember them as I could do, had 40 milligrams for 4, had blocks of steroids. So people were taking 160 milligrams of dexamethasone a week. Absolutely amazing in retrospect. And some very good trials were done that did show that just giving it once a week, as the way we do it now, was just as effective, and you got far less, or far fewer, I should say, infections. So treatments do develop. I think steroids are with us because, you know, they're, as Angelica said, they are so effective, but finding ways to help patients tolerate the treatment is very important. Great. Well, we're spoiling you with breaks. You've got another half-hour break now, and then we're into the home straight after. We've got 2 excellent talks after the break, one on research and another patient viewpoint. So please come back here at 3 o'clock.
We've got one more question. Are you sure?
Oh, one more question. Yeah,
it's a very light question. I know you're not with the pharmaceutical, but is there a reason why dexamethasone comes in 2 milligrams? Okay, so then you need 10 of them or 20 of them. Why not have 1 tablet for 20 or 10?
I think a very good point. A very good point.
Yeah.
They're very cheap, Dexamethasone. The drug companies know there's no money to be made out of doing that, so I'm afraid that that's what we're stuck with. But yeah.
Yeah.
Thank you.